Thank you very much. Delighted to be here. This is the last panel is always a bit difficult, isn't it? And if you look at it, you can compare it with the sort of last live stage that you presented this morning. But I was sort of glad to hear that there is still some learning that can take place. No new synapses will be formed, but maybe some dots might be connected. I'm a child psychiatrist, but I stopped calling myself a psychiatrist many years ago. I'm a public health person. The context in which I'll be talking is South Asia. I'm from Pakistan, and most of my research is based in India and Pakistan. So low and middle income countries, low income settings, and I'll be talking about maternal mental health. Tarun brought this up. I think I've been so glad that the word maternal mental health was mentioned before I did it. And I'm glad the WHO supports this very important, which I think, environmental aspect. Well, it is an important topic, and I think there's no baby without a mother figure, maybe. And I'll be, sort of maternal mental health is a very broad, concept. And I'll focus on maternal depression. The reason I'll focus on that is because from a public health point of view, it's the second most leading cause of disease burden. If you look at the global burden of disease data, following infections and parasitic diseases, so for reproductive health, it's an important condition. It presents with these sort of conglomerate of symptoms. That's how you diagnose depression. There's no biological marker for it. Low mood, loss of interest, feelings of guilt or low self-worth, disturbed sleep, etc. I want you to be mindful of these symptom complex because I'll remind you of these when I talk about the context of child care. It can lead to suicide, so it contributes to maternal mortality as well, and it can become chronic. So I'm going to talk about 4 myths, or states of denial that most of my colleagues and the public have somehow become very entrenched in, when they think about mental health. And so that's my talk, basically. And I try and make an argument that these are myths, not facts. And the first myth is that depression, well, it's rare and maybe it happens only in industrialized countries. 30 years ago when people were doing prevalence studies, they called it a culture-bound syndrome. They said that in developing countries, there were social support networks. Everybody led such a nice, life in a village, supporting each other. That depression was because people had become industrialized. As they started to improve their methodologies, they found out that no, it happens everywhere. And then the opposite thing happened. Strange sort of studies started coming in, quoting rates of depression in low-income countries to 65%, 70%. So people started saying, then well, that's normal then. It's not depression. Everyone, statistically is distressed. So, but then in the last decade, there have been some thorough studies, that have culturally adapted the tools that measure depression. We did one such studies in Pakistan, where we did away with a 2-stage, a screening questionnaire and then a detailed questionnaire, too complex, too culturally difficult to adapt. We went for a single-stage assessment done by clinically experienced mental health professionals working in that region. I was one of them, and my colleague with 10 years of experience of diagnosing depression. We went into a representative community, said, let's try and see what things really are like. And we came up with figures that are not very different from the mean prevalence of 18 to 23%, 1 in 4, 1 in 5 women in the antenatal period, in the postnatal period, does have depression. In South Asia, it's not always serious, severe depression. It sort of teeters on the edge of clinical depression, but it's very much a condition that needs attention. So, and now there have been a few studies and a few systematic reviews that show that it is universal, and the rates using very specific methodologies culturally adapted methodologies are quite high. So that's the myth about it being rare and not being present in developing countries. The second myth is, okay, so lots of women are unhappy, but that doesn't have anything to do with, that doesn't impact child care. And therefore, I think that myth has led to the total neglect of maternal mental health from child development, child survival, and even maternal health agendas, reproductive health agendas. There is now quite a lot of evidence, and it's building every day, that maternal depression has a very strong impact. There is less adequate prenatal care, there's reduced breastfeeding, there's at least 2 meta-analyses that show that it's associated with undernutrition and preterm birth. There's more diarrheal disease, less adequate child care, less responsive feeding, etc., disrupted mother-infant interaction, use of harsh discipline, lower maternal coping skills, and increased family stress. I'll not go into the details of each of these, but the evidence is very much there. You can look up the reviews. So it has quite a proximal and quite a wide-ranging effect on all of the things that we are interested in today and tomorrow. Okay. So no impact on child development, child growth. I hope that that's a myth that the data dispels quite conclusively. Okay, then the third myth. Okay, the third myth is that, okay, all right, so lots of women are unhappy or depressed. Okay, it does have an impact on how the child develops and child health and care. Well, what can be done about it? How many psychiatrists are you going to produce in countries which don't even have, a single psychiatrist sometimes looking after 1 million population, 1 in 4 women with depression? How are you going to have enough resources to go and try and treat these women? Well, I'll cut right to the chase, because this is the fourth panel and won't go into too much details. But this is a meta-analysis that we conducted recently with the WHO. We were able to find 13 trials of interventions that had been done in low-income settings using not specialists, but community health workers, ordinary health workers, who, like the lady health workers in Pakistan, for example, or health visitors in other places, like Jamaica, for example, doing home visits, community-based interventions. And they are effective. As you can see from the diamond, they are effective. The approaches are all very heterogeneous. A number of theoretical interventions have been tested, but most notably there are 2 main domains of interventions that work. One are the interpersonal therapies, and the other is the cognitive behavioral therapies. Now these are very fancy names. I think psychiatrists do it on purpose to mystify their art, so that there is more demand and less people to do it. It all is actually very simple. It's not rocket science. I think a lot of interventions are quite simple if you look at it. If you can glean the principles of what is important and then train people in a way that they understand it, they are able to contextualize those principles to their environment. And I'm talking about depression, but some of this experimentation that we have been doing could probably be applied to child development also. Because I'm also not in favor of packages that come from above and have to be delivered, exactly as it says on the tin. It doesn't work, in my experience. So you have to but take the principles, and then those principles, and trust the intelligence of ordinary, health workers, experienced, deeply entrenched in the universe of their clientele, are able to very quickly pinpoint, but supervise them very carefully, so that they stick to the fidelity of those principles, and you're able to get results. And so our trial, which is here, we were able to achieve some very good results with community health workers. Actually, if you look at, psychotherapy trials done with very, very qualified psychotherapists, our lady health workers did a better job. So that's hopefully another myth that the data can dispel. You can treat depression. You can train ordinary health workers to treat depression. Okay. And the benefits, obviously, improving maternal mood and improving maternal depression is a very important outcome in its own right. But you can also achieve better cognitive development and growth outcomes. So in the meta-analysis, in some of the studies where these things were measured, there were no significant improvements in cognitive development and growth. But also some of the side outcomes that community health workers are supposed to focus on in their day-to-day work, like diarrhea, for example, is a big deal in my part of the world, and so one of the main job descriptions is to counsel people about diarrhea, how to prevent it, and how to treat it. There was reduced numbers of diarrheal episodes and increased immunization rates. So talking to women with distress and accessing and engaging them can have programmatic benefits. That's often a point that is missed. Okay, yeah, the fourth and the final myth is, and I've got 3.5 minutes to try and dispel it, it's probably one of the most challenging ones, is how do you integrate then a maternal mental health intervention into programs like child development or child nutrition or maternal and child health? And that was the topic of this series in PLAWS-Med that we did under the NIH and Pamela Collins's leadership of integrating mental health interventions into a number of platforms that are out there and available. And we talked about maternal mental health. And so very briefly, what we did was we took our intervention that we did with the lady health workers in Pakistan. We went back to the lady health workers after a couple of years and asked them, are you still using some of the things that you were trained to do? And to our pleasant surprise, they were still using some of the things. So we interviewed about 40 of them and then did a sort of thematic analysis and came up with techniques that they found very intuitive. They had been able to use them and were still using them in their day-to-day work. I don't have time to report in great amount of detail how we then integrated the approaches that we developed out of those cognitive behavioral approaches that they were still using. But you can read the details of this in this paper. It's available for free. It's part of a series that the Academy of Sciences, Annals of Academy of Sciences, just come out, I think, a couple of months ago. Leah's also one of the, I think, editors of that. It's free and it's all about integration, how to integrate various things in child nutrition and child development. I do recommend. And our particular paper talks about how we integrated maternal mental health into a child nutrition and child development program that we are currently testing in 2 countries, India and Pakistan, a Wellcome Trust funded trial of 12,000 kids. And so the central sort of machinery behind it is the intervention that focuses on mothers. Basically, the things that the health workers found very useful were these 5: family support, empathic listening, guided discovery using pictures, behavioral activation, problem solving. I don't have time. I do have slides which tell you what these things are, what these pillars are. And these slides were there to, again, dispel the myth that this is something that's very, to demystify these therapies. They're very common sense things. They have a lot of commonalities with behavior change communication principles, principles of delivering programs in an effective way. A lot of things you will find very familiar. And that's what therapy is, basically. So empathic listening, it's nothing rocket science about it, challenging beliefs. I don't have the time to really go through these, but I recommend reading the paper. We've done a pilot study as part of the formative research that leads into the trial, and our pilot has shown that community health workers can be trained in the approach without adding too much burden to their already heavy portfolio of doing a lot of things. It improves their skills, and it is both feasible and acceptable both to the health workers and the mothers. So in summary, mental health problems, especially depression, are common in women in the critical perinatal period, associated with negative outcomes in the child, especially growth and development. Intervention for maternal psychosocial well-being can be delivered by non-specialists and benefits both the mother and the child, and should be integrated into maternal and child health programs. And just my final slide is that mental health is too important to be left in the hands of mental health specialists.
Thank you, Atif, for myth busting. Great. Okay, next we will hear from Amina Abu Bakr from the Kenya Medical Research Institute. She's going to be talking about HIV-affected children.